Second part of our prostate session, also a podcast, is on Radioligands, very timely. Same panel, we brought up Gary Smith, my friend and colleague from Vanderbilt. Gary, you want to just introduce yourself briefly?
Yeah, Gary Smith, one of the nuclear medicine physicians at Vanderbilt, and certainly not expert in the clinical trials that you all are. It's a pleasure to be here and meet with you. My interest is in quantitative PET imaging, so yeah.
Yeah, and Gary and I work together and treat a lot of patients, so appreciate you reinforcing our panel here. And I'll just read it for the podcast audience. We're also here with Mike Morris, Tanya Dorff, and Karen Autio, and we're going to talk about radioligands. So this is the lutetium radioligand data. Michael, maybe I'll let you sort of walk through this.
Sure. So for those who are audio only, which I think is most of the audience, we're showing a comparison of VISION and PSMA-4, which, as most would know, looked at two different patient populations. VISION was the latest patient population post-ARPI and post-chemotherapy, whereas PSMA-4 was post-ARPI pre-chemotherapy. Just following along a general prostate cancer drug development scheme that what works late, you just then move earlier and earlier. And to date, that has been met with pretty much universal success without exception, especially now that we have the results from Piece 3, which we're going to talk about later. But VISION was a straight-up success in terms of its outcomes. This was basically a randomization one-to-one of these patients to either a protocol-defined standard of care alone or protocol standard of care with lutetium. These were all PSMA-positive patients by a gallium-68 PSMA PET-CT. And, whether you were looking at feel, function, or survive, this was a successful trial. It hit domains in all three key clinical endpoints for regulatory approval, with RPFS and OS being both primary endpoints, and then the FACT-P, several other quality of life assessments, a pain assessment score being secondary endpoints, and basically the trial was successful at all of those.
Michael, remind us when you say PSMA PET positive, remind me how that was defined for the trial.
Quite loosely, it was only about a 13% screen failure rate. Basically, there was no dual scanning. It was just basically gallium PSMA PET with exclusion of patients who either had negative nodes, viscera, or bone, or soft tissue component of bone by various size criteria. So it was relatively liberal compared with like the Australian approach, which had really high standards for getting patients on their studies. Now, PSMA-4 has now had several different pre-planned analyses, and the primary endpoint is mature. The primary endpoint is RPFS, and that clearly was positive with a hazard ratio at its latest look at, of 0.43. This trial had a built-in designed crossover from the control arm for patients who met the primary endpoint to receive lutetium as part of their post-protocol therapy. So that was done on the basis of the feeling from VISION that if you had a life-prolonging therapy and you were offering a randomized trial, that you should have a shot at that therapy if you were on the control arm. Ultimately, however, and I'm not saying that it's necessarily causal, but you can't ignore the fact that, over half the patients did cross over in this study. And if you look at the eligible patients, around 80% of them crossed over from the control arm. But OS has a point value of 0.98 with a confidence interval, and this is a secondary endpoint, so it's not part of the design for statistical validity, but the confidence interval does cross one at 0.75 at the lower bound to 1.28 at the upper bound.
And reinforcing your point, the RPFS hazard ratios in essence identical, right, but very different OS.
Yeah.
Right, same drug, same PET positivity criteria.
Very similar.
Similar, almost identical.
Yeah.
I want to talk a little bit before we move on about sort of implementation in practice. And Gary, to bring you in, we see a ton of patients, and we've been a referral center. They come from all over. They have these outside PET scans. and we don't know. I'm certain that we're treating patients. You can reinforce that we're treating patients who would not have fit in criteria for the vision study.
That's right.
How do you think it's 10% of the patients we treat? Is it 60%? I don't know.
That would have not
qualified for vision study
criteria
or
for this.
PSMA-4, but we're treating anyway.
Yeah, so we do clearly treat a different population than these clinical studies in real-world data. I think we recently published an abstract showing that our results for PSMA did not match the vision trial. Sure. But the reason for that, I think, is our patient population clearly higher comorbidities than in the vision trial. So we do take PSMA PET scans from outside for patients who are referred from outside centers. We currently have 30 patients that we're in treatment right now for PSMA, and I would say about half of those would not have met the clinical
vision criteria.
Yeah.
And how often on an outside read do we change from PSMA PET positive to not? Do you know what I'm asking?
Not very often.
Not very often.
Yeah.
So the outside reads are pretty faithful in terms of.
Yeah, we
SUV
read the PET scans on all the patients that come in. We review those and review the outside reports for those PET scans and look at those to make sure that we concur with the outside reads.
It's generally.
And generally, we're pretty
in
close.
the same ballpark.
Yeah.
Gary, are you treating patients in the PSMA-4 patient population, which just, again, for the audience's benefit, that was a trial of patients who had progressed on one ARPI and were randomized to either lutetium or a second ARPI. At Vanderbilt, are you treating those patients?
We're beginning.
FDA has not adjudicated this yet, so that
Yeah, we're beginning to see patients earlier and earlier in their
I think
therapy.
almost all the patients I refer are pre-chemo. Am I the only one? Katie? Gary? Maybe I'm the only one. How about Michael, are you doing that in practice or are the others?
Really very, very infrequently at this point, but I think that is
Because
obviously...
Why?
I think that there is concern about the reimbursement issues, treating it off-label as to whether the institution will ultimately recover those costs. And I think anytime you need to prioritize patients due to constraints of resources, rooms, staff, pharmacy, et cetera, that you're going to favor the patient who will have a survival benefit as opposed to the patient who won't.
Even though you think that the lack of survival benefit is strictly a crossover
We don't.
issue. Not to put words in
I'm
your
not
mouth,
saying
but
that.
I just did,
I'm
yeah.
saying that
Yeah.
I don't know that those are causally related.
Yeah.
But if I have to choose two patients and I have to make a difficult decision, let's say we only have one chair available, I'm going to give it to the patient that I know has a survival benefit.
Fair enough.
That's not to say that I think PSMA-4 isn't outstanding therapy and you haven't shown the quality of life data. It is better in terms to be a patient with prostate cancer to get lutetium rather than a second-line ARPI from a quality of life standpoint. But if I have a limited resource and I can only allocate it to one, I'm going to favor the patient who is going to live longer as a result.
Fair enough. Shilpa?
Brian, at our institution, we can almost never get pre-chemo reimbursement for lutetium. So even if we want to give it, we cannot.
Gary, have we had problems? Am I the only one doing this? Say that again. Yeah. We're just giving
You'll
it.
get a call later.
Yeah, I'm going to get a call
Now that
after
you
the session.
publicize this.
That Brian Rini has single-handedly brought the black ink into red.
Yeah. It's coming out of my salary. Yeah, ineligible for chemo. I got you.
We have tried that too.
But it hasn't worked.
Yeah.
Okay. Things are different here in Tennessee. All right. This is Michael was alluding to this, these different, I guess, non-RPFS, non-survival, like how a patient feels, maybe best stated. And I think, Mike, we were talking about these slides before. This really, and again, tell me if you think this is true, this reinforces that RPFS advantage, right? We don't just want to see scans changing. It's why the FDA has been somewhat reluctant to approve drugs based on response rate or RPFS historically, although not recently.
Yeah.
Because if it's just a scan change, who cares, right? If the patient's not feeling
Yeah,
better.
stuff we just measure is irrelevant if it doesn't help how patients live. But stuff that helps how you live as a cancer patient, I think is incredibly important. And I actually think that a lot of our community gives not enough service to how therapy improves the quality of life and the experience of living as a cancer patient. When these data were presented at ESMO last week or 2 weeks ago, and it was clear that in every measure, you lived better as a prostate cancer patient getting Pluvicto as opposed to an ARPI. First guy at the microphone said, yeah, but what about the OS? And it's like, wait a minute, are we just saying that quality of life is important, or do we not actually believe that?
Yeah.
So I think that this shows that, yes, our PFS as a radiographic metric is delayed, tumor control is extended, and that then also means that you have a delay in degradation of quality of life, time to worsening pain intensity, time to worsening pain interference, also delayed SSEs. So it's not just something that we are measuring in the reading room.
Yeah.
It is actually translating into a better life for a cancer patient. I personally think that alone, even if you do not live 1 day longer, is worth getting or having access to as a patient. I get that in certain healthcare systems, the value calculus is really important because lutetium is not cheap. But in our system, at least, how you live is just as important as how long you live.
Mike, that is a very important comment because back in the day, mitoxantrone was approved. It did not improve survival, but it was mainly for palliation of symptoms. So I think looking at this is not very often we see such quality of life data for active therapies.
But the question, I guess, so I've been very gratified. Some patients after one dose of Pluvicto are pain-free and their life is completely improved. So I think it works very well. But how would these numbers have looked with a more active control arm, right? Mm-hmm. Would docetaxel also have improved the quality of life by controlling the cancer symptoms?
Well,
maybe not as well, but we don't know.
At ESMO, you do have a hint of that, right? So the upfront PSMA study was presented. This is for hormone-sensitive
We're going to get there. Yeah.
disease. But I won't blow the wind out of those sails, but to address that point, there wasn't an apparent improvement of quality of life with the addition of lutetium, but that's probably because your quality of life is so eroded by docetaxel that it is essentially the dominant picture of quality of life erosion. And I think that also speaks to the issue of the control arm here, that there, even though everyone will say, and this came up as a passionate debate between me and Nick at the last meeting last year, is a control arm that doesn't involve chemotherapy ethical. But in terms of the real world, what patients want is to avoid chemotherapy. And the reason that they want to avoid chemotherapy is because of decrement quality of life. And so if their choice is a second-line ARPI, now they have something that's more active than an ARPI without the side effects of chemotherapy. So I think that there is a valuable lesson there for the patient population, even without a control arm, that both degrades quality of life and improves overall survival.
And
Sorry, I have a question.
That is docetaxel, I mean. Not Pluvicto.
We all have these patients that have exceptional responses too, maybe after a couple cycles. How are you reassessing these patients, and are you de-escalating treatment as far as extending the interval beyond the FDA label?
That's a question that Jeremy Calais will need to answer in a few years. He's opened up a study looking at adaptive dosing of Pluvicto. So we will see what that study shows, but we've certainly put our money where our mouth is. You'll see an actinium HK2-directed therapy where we are adaptive dosing. I personally do reassess the patient after every 2 cycles. As a group, we've decided to do that with a PSMA PET. And if they do have a CR and they're feeling much better and there's just nothing else to treat and the dosimetry against the tumor with further dosing will just be negligible, but the administered activity to the rest of the body will just be, the 7.4 gigabecquerels, then yes, we do stop at
So you're doing
MSK.
PSMA PETs after every 2 doses?
Yes.
Okay. And no insurance problems getting
None
those
whatsoever.
scans? Okay.
Yeah. Yes, and in Vision, you got your 6 doses every 6 weeks, no matter what
Regardless.
happens, right? Except, of course, clinical progression. But yeah, we are keeping our powder dry for a rainier day, and it also scientifically makes little sense if you're delivering no radiation therapy because there's no tumor visualized, like how much mileage you're going to get out of that dose.
And then you're retreating if they become PSMA PET positive?
Yeah.
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 Tanya, we talked about this last year. This was, I think
Yeah.
you had a different opinion about scanning, or maybe it was
I
Raina.
use PSMA PET,
Okay.
even though we're not supposed to because they didn't envision. But I think exactly what you explained makes a lot of sense. But I don't always use it in isolation to gauge whether a patient's benefiting. Like, it's clear the case you described, but you have cases where the pain goes away, the patient feels better, and the scan doesn't look better. And PSA is maybe up, maybe it's down, ALK-Phos. You look at it all in context, and we'll continue treating, even with the scan. So we don't fully know how to utilize the scans, but I think it makes sense to be getting them and learning, like building our experience with what does a PSMA PET scan look like after 2 and 4 doses.
Tanya's 100% right. Yeah.
And I think we're learning a lot about the heterogeneity when we get these scans before the 3rd cycle also, right? The case of a CR I don't think is common,
Yeah.
where we're saying, do we need to keep going? But the case of there's a mixed response is very common.
Yeah, I was going to ask Gary. I mean, I think I tend to get it after 3 cycles. I think we decided after last year's meeting.
Yeah.
We decided as a group. But I often don't know what to do with that because the PSA is, it's not as clear as, oh, CR, everybody's great, let's just stop. I mean, I'm not sure I've ever seen that, but Gary, I just wanted to ask you, like, how much, when you're interpreting those mid-cycle scans, the mid-treatment course scans.
Yeah, just want to go back to the quality of life issue very quickly. Historically, nuclear medicine has had several tracers, several treatment options for skeletal bone pain that have been abandoned mostly. We still have radium-223 available, which is primarily palliative for bone pain, but does have some survival benefit as well. PSMA is the latest one in that line, and it's not just for skeletal, it's for non-skeletal disease as well. When you start looking at interim scans, historically we have not done interim scans, but we're beginning to see more. I think we're starting to see post-3rd cycle scans being done. What to do with that? That's a great question. But
Are they harder to read for some reason? Or
they're not harder to
Not
read. I think
necessarily.
what we're looking for is to make sure that these lesions are still PSMA avid, because it makes clinical sense that those would be the ones who would respond to continued therapy. But there is a lot of work being done in dosimetry for patients who are receiving lutetium-177 to do post-treatment imaging within the first day to 3 days post-therapy. And there are a number of different protocols that are being developed. Some of the more rigorous ones are doing multiple scans over 3 or 4 days and looking at the kinetics of the lutetium and trying to do dosimetry for individual lesions. Some of the ones that are a little bit more patient-friendly, if you will, are doing single scans 2 days after therapy and trying to extrapolate from the image data what the dose to these tumors are. And I think that dosimetry is something that we need to be aggressively pursuing. I think it's that's going to dictate whether or not to continue therapy more than the interim PSMA scan, quite frankly.
It sounds like there's a lot of work to do in terms of, it's not just like get a scan, it's positive and treat.
Yeah.
Right. I mean, it's obviously more sophisticated, but we haven't really gone down that path and developed those algorithms.
I
Right?
just want to pick up one thing
Yeah.
that Gary was talking about, and he's absolutely right. We've long had therapy that improved quality of life in strontium and samarium.
That's right.
But the oncologic community always complained, well, but that doesn't prolong survival. So then we had radium, which prolonged survival and made you feel better. And still, oncologists were like, yeah, that's nice. And now we have piece 3 showing that in earlier patients, in combo with ENZA, it will prolong life as well. And this is a drug with nearly no side effects. I mean, the impact on the marrow is like 4% to 6%. So I would really like our community to put their money where their mouth is, because these tools are available, and they have been available for a long time and simply underutilized.
Yeah, and I think that is, radium-223 is still an option for primary skeletal disease. They allow a small burden of nodal disease with radium-223, but primarily skeletal metastases.
And we're going to talk about piece 3 at the end. Shilpa.
Hard to discuss with the patient what each SUV means, when they report a progression of disease with all of them are SUV 3 or 4, which may not even be clinically significant. Like, can we as a community come up with the threshold for the SUV where it's clinically meaningful? Because patients start freaking out that everything is lighting up, even though Envision SUV of 10 was the cutoff.
So, Shilpa, I'd like to take a different approach. Everybody, no matter what their SUV in Vision, if they got lutetium, they did better than if they did not. The SUV mean, which is not a routinely reported metric on your average clinical report of 10, was only there as a guide for who might most benefit from, but that's been misinterpreted as if you have an SUV mean of less than 10, seek some other treatment. So if we establish a threshold, I think that people tend to forget that these are continuous data, and that generally speaking, getting lutetium is good for you if you have no other treatment choices. And so I would, unless the community understands what the meaning of the threshold is, it seems to be being misinterpreted as do not treat if the SUV mean is less than 10. And that was never the intent, and that's not the statistical message. It's just really a reference point, and I'm not even sure that it's so clear that it's anything other than prognostic. But it's a reference point above which you are anticipated to have the greatest response, but it doesn't mean you're not a responder if you have an SUV of 7.
So I totally agree, and I was going to elaborate on that issue before. I totally agree what you're saying. It's a spectrum, but I think at the same time, the problem is that the control arm of Vision did not have chemotherapy, if I recall. So you have a typical patient who had docetaxel before and now is in the Vision population, and it would have, especially for good PS patients who are contemplating survival as well as toxicity, they would have cabazitaxel as another option. And so the question has come up, for those patients with that the scan is called positive, but it's borderline positive, is it really the best option for them? And the other issue is the issue about restaging upon progression, 2 cycles, 3 cycles. I commonly do 2 cycles because I think Vision did every 2 cycles. So if you have a patient with significant PSA rise and radiographic progression over 3 cycles, the more you continue with lutetium, the more cytopenias you'll have long term that I find very difficult to rescue the patient with Cabazi later. So is this a patient that you typically stop after 2 cycles if you see significant PSA rise and switch to Cabazi? Are you even using the PSMA quartiles, the lutetium quartiles, to make that decision process? What is your approach?
There's a lot packed into that. So, as I recall, 40% of patients on Vision had already had cabazitaxel, so that they did not have a whole other spectrum of options. But certainly if you have a patient who could get cabazitaxel, and their SUV mean is on the lower side. And I would take the totality of the other data on their counts and their performance status, the goals that they have for their care, because I do think that lutetium has a very different side effect profile than cabazitaxel does. Then that's all reasonable information to integrate with the totality of the patient's picture to make a treatment decision that says, I will not give you Pluvicto, right? And you might integrate into that, clearly, SUV mean or SUV max. But if they don't have another choice, obviously, then it's a moot issue.
But it's often, when you're making decisions for patients, it's not necessarily one or the other. It's, A then B or B then A,
Yeah.
right? So which one is best now for this patient? We all make those decisions all the time. Doesn't mean they can't get it later. Now, many don't or can't. But,
Right.
Yeah.
And it depends also, what's their visceral disease look like? What are the hepatic metastases, which generally don't have that much PSMA avidity relative to their bony disease, and that's going to drive prognosis. And maybe you want to do cabazitaxel in that circumstance.
Do one more question.
Yeah, one question. I mean, Stephanie and I have that experience. We're seeing way more bone marrow suppression than what's reported. People run in low platelet all the time. To a degree, we're asking ourselves, which should come first? Should we give the, lutetium PSMA earlier? Should we give all the chemo possible and leave it till late, etc.? But there is no doubt we're seeing mostly thrombocytopenia than what's reported. I want to see what your experience is.
I would again move you off that point. The point is not to get any specific therapy in your lifetime. The point is to live as longest and as best as you can. Let's say you gave a therapy that precluded a magical therapy, that precluded all subsequent therapy as a single dose up front.
Curitinib.
But it left you with a platelet count for the rest of your life of 70. Okay? So you could get no further therapy ever. That's considered to be life-prolonging. But it had durable disease control. Is that good or bad? That's good, right? So when we say, well, the patient can't get chemotherapy later on, there's nothing special about getting chemotherapy, or vice versa. Well, the patient, because we're going to move, I hope, radium to first-line metastatic CRPC. And then someone's going to say, yeah, but maybe, in 3 years they can't get docetaxel. That's not the point.
Yeah.
The point is how long are these patients living with a given sequence, and how well are they living with a given sequence? Not can we cram every therapy into them because that has its intrinsic value. It's really the survival calculus.
You give whatever you think is the best therapy at the time, and you put the others to the side, and you pull them out later if needed. Right. All right, we're on slide 2. We're making great progress. All right, Oliver Sartor presented SPLASH. Yes, what time's lunch? Oliver Sartor presented SPLASH at ESMO, which is on the right-hand side here, rPFS and OS. You see rPFS hazard ratio 0.71, and note the medians there of 9.5 and 6, which are different than we saw with the lutetium data, and then no OS difference, right? Those overlapping curves. And the discussant, made a point that it was all about dose, right? That's sort of what I took from that discussion, that it was all about dose. And you see sort of the dose calculations on the bottom there, 44 versus 27, 40% difference. So I guess, is it true that dose matters, right? And maybe, Gary, I'll start with you. How do you think about, and we're balancing toxicity, as mentioned, cytopenias, do we know what dose to give? I mean, we're giving the standard dose, but it seems to me that we're just sort of starting to learn about this dose effect.
Yeah, so I actually was at the Society of Nuclear Medicine Therapeutics conference last week in Washington, and one of the presenters presented data to suggest that if we look at total body burden of disease as opposed to single lesion SUV, that potentially will correlate better with response. It's actually inversely correlated, as might be expected, that the higher total body burden of disease, if we're given a single dose of 200 millicuries or a slightly reduced dose of 160 of the Pluvicto, that's distributed across more lesions and has less total radiation. So it may be that what we needed to be doing is, again, this dosimetry step to try to predict the dosimetry to individual lesions and specific lesions. One of the difficulties with that is that until we get dosimetry-specific guidance on dosing, rather than giving a single dose of 200, that it may not make any difference to do that. But I think that there is data to suggest that the dose is important, and the difference between these is significant, I think.
And I don't know enough about the other agent and how it was developed. I mean, why was it a lower dose? I mean,
this is the intersection of clinical science and regulatory science. This dose was reduced by the agency, basically, out of concern that the patients would get too much radiation, and that was...
Even though it's less than...
Well, that was regulatorily determined, that the dose couldn't be 7.4, had to be given at 6.8 times 4, as opposed to times 6, and given at Q8 weeks rather than Q6 weeks. So I think that this is an ongoing discussion. There was a big meeting this spring with NMMI and the FDA about how to approach this issue in the future, and where the line is, where you say, well, I'm going to try to spare the patient risks of side effects from radiation, but then you expose the patient to the risks of poorer tumor control.
Right.
And it's that balance that I think that everyone is now struggling with. And unfortunately, I do think SPLASH was the victim of being one of the first to be in that battle.
Bad timing.
Yeah.
But I think, as we talked about with the bispecific T-cell engagers, we are getting better with subsequent iterations. We're tweaking, and there may be something about how the target is bound by the drug, as well as different particles. Like lutetium PSMA is wonderful, but it's not the end. It's the beginning of this frontier, and we need to continue to develop new doses, new strategies, and new agents that will get more dose to the tumor.
The targeting agent for SPLASH is not PSMA 617.
Right.
So that raised some concerns from a regulatory standpoint.
So I want to cover two trials, this one and then piece 3, which is important, that we alluded to. So this was upfront PSA. This was Arun Assad. Australian group's done a lot of these investigator-initiated randomized phase 2, the therapy and this one, and I think others, Enzapi, if I remember correctly. This was hormone-sensitive disease, so to my knowledge, the first experience with lutetium PSMA and hormone-sensitive disease. High tumor PSMA uptake, I don't have the definition there, and high volume disease because it was docetaxel-based, either standard ADT docetaxel, that should say, or adding two doses of lutetium PSA before the docetaxel. And we did a podcast with Arun, and it was really just sort of a very practical decision of, well, we don't know how many to give. Maybe we can't give them at the same time, so let's give 2, which is totally understandable in an IIT. They looked at undetectable PSA at week 48 as the primary endpoint, which we can talk about. You see there was a significant difference, 41 versus 16%. You see the other PSMA parameters there. And then PSA progression and RPFS in the Kaplan-Meier curves. I basically summarized a ton of data on this one slide, including sort of the bullet points. So and the next slide is on PSMA addition, which we'll talk about, but how does this help us? It was safe, right? There was a little more cytopenias, as I remember, but there weren't big toxicity signals. I know Michael's opinion, Tanya. I'm looking at you. I don't know if you have an opinion on this.
I think it continues the story that we've been seeing in the metastatic hormone-sensitive prostate cancer space, which is that more treatment upfront is helpful, that we want to try to debulk as much as possible and achieve a deeper remission. But this is not a regimen. ADT docetaxel alone is not a regimen now that NCCN recommends. So unfortunately, clinical practice evolved during the time period after this was developed. And so it doesn't answer the question of, in the context of using an AR pathway inhibitor, would we have gotten the same results? But I think it just tells that same story that we're seeing over and over again of intensification.
Michael, is it really just mostly about feasibility, safety?
As designed, yes.
Yeah.
If you have a biochemical time to BCR failure, which isn't biochemical relapse-free survival even, right? It's just time to the PSA. That's really not a clinically informative endpoint. So this is going to just speak, in essence, to feasibility. I think that this is where the rubber hits the road in terms of how do you design an early phase trial with information that will allow you to say, is this a go, no-go decision? And I think you have to have some respected either clinical or regulatory recognized endpoint to inform you of that. That could be rPFS, that could be, if it's an even earlier treatment population, MFS for the non-metastatic group, but I don't know what to make of this. And in the end, first of all, PSA, time to PSA progression has not been a reliable predictor of a phase 3 outcome. Time to castration resistance is even more poor because many patients spend more time in CRPC now than they do in CSPC. And I think that it's great to have shown the feasibility of this. I don't think that's on the slide, but quality of life was the same of the two groups.
Yeah, just a bullet point.
If you're not improving how patients feel and you don't have the clinically informative endpoints here, then it's tough to sink your teeth into where you go with this.
Yeah.
But I do think for a primary endpoint of undetectable PSA at week 48, we have data across multiple trials charted, that do show it's predictive. And so I think for a short signal-seeking early stage trial, I think it was a very reasonable endpoint and clearly showed efficacy for the combination over upfront docetaxel, which certainly isn't the standard of care now. But I think you can't get too lofty in a phase 1 as to what you're going to get at it in terms of rPFS.
Yeah, fair enough. This is PSMA addition. I don't know where this stands in terms of timeline, if anybody knows or can say, right? But this will be presumably the definitive test of lutetium PSMA in the hormone-sensitive setting. Obviously, this is different than the upfront PSMA we just looked at. This is the same Q6 weekly, 6 doses plus standard of care. Primary endpoint rPFS, obviously OS as well. Predictions whether completed accrual. Okay. They probably allow people that started hormones within some period of time.
Right.
Just a practical.
Yeah. So the reason. Well, I have to stand behind it. Sorry. So no, Scott is, but the reason for that is that many patients, for their primary disease, will get radiation and hormonal therapy, and then will develop metastatic disease. So the aim was not to exclude those patients who may have received hormonal therapy up front for their primary treatment, and exclude them from this trial when they metastasized. And you'll see that there's a little footnote there, Tony, for minimally treated as to what it means, and that footnote is defined in the protocol as no more than X number of months. So.
You guys, unlike kidney, where we're black and white,
But I'm on the stage with these guys here to throw me under the bus. All right, let's get to piece 3 before we wrap up. Our friend and colleague Silke Gillison presented these data at ESMO in a presidential session. This was ENZA plus minus radium-223 in a metastatic CRPC setting. We can see again in the era that this accrued that this was 30% prior treatment with docetaxel, only a small percentage, 2 or 3% of prior ABI, again, just given sort of the timeline of this trial. So not necessarily the modern CRPC patients we see, at least in the US, but probably globally around the world to some extent. And I think, I don't know, maybe somewhat surprisingly, you all can tell me, both an rPFS and an OS advantage with identical hazard ratios, which we don't see too much, right, where that preservation of rPFS efficacy is carried through to OS. And as we said, radium's sort of just don't know why. It has like a bad personality. I don't know. It just hasn't like. I remember when the first the Alsimca trial came out. It was like surprisingly positive, right? But then it didn't get much use. So, who wants to sort of jump in terms of? I mean, this is a new standard of care, right? Overall survival benefit in CRPC. Number one, do you agree with that? And number two, how do you think it's going to be used in clinical practice, given sort of some of the parameters of the trial? Tanya?
I think we need to still be doing NGS. We need to be testing our patients to see, because this is the same population as the PARP inhibitor and AR pathway inhibitor combinations, theoretically.
We were trying to avoid PARP inhibitors this meeting. Yes.
So, sorry, I didn't get the memo. I'm just saying, like, yes, this is a new option, but it's not the only one,
Sure.
and it's important that we remember to use genomic markers as
How would you use it?
selection.
Assume regulatory approval, your current practice of CRPC, whatever patient mix you see.
Well, most of my patients get upfront doublet, and
Yep.
that wasn't really represented.
And you would not
here.
use it in a patient who got upfront doublet.
I would never say never. I think I'd have to inform the patient that we don't know what these results would look like in the context of having progressed on abiraterone, but if they have a heavy burden of bone disease, and symptoms, I think it's very nice to be able to give these together, and I don't think we're going to get too much pushback in that population, but I could be wrong.
From payers.
We'll see what payers.
And you were shaking your head.
I don't remember at what comment, but
Yes or no,
if
yeah.
was it an agreement? No, I mean, I think the drug shows the trial shows the synergy of two active drugs, so it's not surprising to me at all. I think the first-line CRPC population is, at least in my practice, something that I don't see very often, because all of my patients are getting doublet therapies. But for those who have not, I think it's something that should be given.
Gary, how much radium are we giving?
I don't recall the last radium dose that we actually gave.
I've definitely given it, but it's been a while.
Yeah.
It's been a minute, so
It has been a while.
It's not used.
Because the combo will lower PSA in a way that radium alone does not, I wonder if that will help with the adoption of the
Yeah, fair enough.
combination. Because I think some of the hesitancy on radium was understanding on an individual level if
If it's
somebody was
working or
actually
not.
benefiting
Yeah.
or not. So maybe in combo that will.
Also, now that we have the lutetium and we're more used to sharing our patients and this multidisciplinary management with nuclear medicine or radiation oncology, I think back then, it was easier to keep the patient in your practice and give chemotherapy than have to refer them out. And not every hospital gives radium-223,
Right.
just like not every hospital will give lutetium-177. But we're getting more used to that.
Yeah, the operational pathways are more smooth now. Yeah. Michael?
Just 3 quick points. First, DORA, which is DOSI versus DOSI and radium, is ongoing, and I hope that these data put a lift under the sails.
CRPC, metastatic
CRPC, yep. So that trial is open and accruing across the U.S., Spain, and Brazil. So
And presumably a lot of
the
those
Netherlands.
patients will have had prior ARPI.
Yeah.
Almost all.
They have to be DOSI candidates. So,
Yeah, okay.
Second, I think you made a really astute observation about how the hazard ratio is preserved from RPFS
Thank you,
to
Michael.
OS.
Appreciate you saying that.
And of course, most RPFS events are bony. And this is bone-directed therapy. And indeed, the lethality of the alpha emission is primarily to the osteoblast and osteoclast rather than the tumor cell. And that speaks that radium's really different than most other therapies. You don't expect to see a PSA decline. The primary anticipator of longevity with radium is a change in bone markers, bone turnover markers, not PSA. So I'm not surprised that RPFS, from a hazard ratio standpoint, is essentially the OS advantage, and also shows sort of not the usual absolute, usually we're used to seeing absolute really huge differences in RPFS between the two arms as opposed to OS. So, bone scans sort of lose their value to some degree with radium because you are targeting the very thing that is making the bone scan positive, which is osteoblastic deposition of hydroxyapatite. And then thirdly, yes, I do think that this is a new standard of care. It doesn't speak to a current patient population, but it's really important, I think, that not to forget that old drugs that aren't the shiniest new penny on the ground and that have these data, much like Charted did for chemotherapy. These are actually really valuable tools. And we should definitely, we have been underusing radium, and shouldn't forget that, you know, this is a positive trial for a patient population, not so common anymore, but when you see these patients, think about it.
How will you use it in practice?
I, like everyone else on the panel, generally, this is a moot question. I don't see that many patients who have not received it. But to answer your question about, and Tanya's as well, who might I use it? So let's say I had a non-HRD patient and non-Lynch patient, and he had a bone scan full of metastases, and he was not a chemotherapy candidate absolutely for some other reason.
Okay.
I would use radium and Enza in that patient.
And he's never had Abby.
And well, yeah, and I'm presuming he no, I'm really talking about in the second line setting.
Okay.
Like when would I, because Tanya said I would never say never, but that's the circumstance where I would
Even
say.
if they had this patient had prior Abby.
Yeah.
Because they're, I got you.
Yeah.
Petros, quick question?
Guys, this is wonderful. The question I have is more generic about drug development at this modern era in prostate cancer. Because of all these new agents and we're miles ahead compared to 10 years ago, do we really need overall survival these days? Can we get by with RPFS and quality of life endpoints? Can we say, because many people in the industry are here, can we redefine the metric of success? Question mark. Thank you.
Short question, long discussion. Petros.
This is a short question.
I mean, I think that's a big drug development question. I think it kind of depends on the context, right? I mean, in some settings, RPFS with quality of life endpoints is super valuable, right? We always want OS, of course, right? But is it mandatory? I don't think so. Michael, we can
You
kind
have
of
to
go
push
down.
me really hard to ever do a crossover study again. I think we've paid for that now. Twice, and with PSMA addition, we'll probably pay for it again. I think it was a mistake to try to offer that. In the end, we probably will hurt more patients if it jeopardizes approval of active therapy than have helped the patients on the study to offer them the opportunity to get the drug, especially since it's approved for later use.
That's a big discussion.
No, the Titan study did have crossover and showed OS advantage, so, but you're saying that we should not be doing those?
Well, I think that's such a good segue to the questions.
I think my question may have gotten lost in the slide shuffle.
You're
Let me
right.
see.
Why? And I was really
Yeah, it did.
careful to separate myself from saying that it was the crossover that was responsible. I don't know that. It could be that its lutetium isn't potent enough. It's possible that the alphas will need to have that extra potency to sort of get over the hump. And it could be, like I sort of really casually said, that only 13 patients screen failed from vision, and 8% screen failed from PSMA4. Maybe our criteria are too liberal. Maybe we're not enriching enough. Maybe we should raise the bar in terms of positivity, take out the visceral metastases that have the least amount of benefit, and have trials that have greater enrichment for success if we are going to focus on OS.
Which means more selection bias.
Oh, of course, yeah, and less real world, and you know, and perhaps lending credence to the Australian approach, which was double scanning and SUV max of at least 20, you know, for any single lesion, et cetera. You know, if.
But maybe that's why the treatment that shall not be named had an OS benefit despite crossover, because the biomarker was better, right?
Absolutely.
BRCA2 is such a good biomarker.
You're absolutely right. Yeah.
Just one more question, Mike. Because all these lutetium moving earlier and earlier, and you know we are part of PSMA addition, we put the highest number of patients in the country. We are seeing neuroendocrine transformation early on with the lutetium combination. So I think while the enthusiasm is really great to move these even earlier on, we need to temper it before we know long-term safety data of these drugs.
And I actually think the P10RB, P53 group should be considered its own disease entity. I really do. We should be studying those patients for what's the best for them for early intervention of therapy as its own pseudo-orphan disease because they are
Different
special.
biology.
Yeah.
Quickly, Michael, HK2 actinium, you've worked with this drug.
Yeah, so I think that, the biggest limitation for going to alpha PSMA is directed therapy for the small molecules is xerostomia, and also a totally new target and one which has been around for a long time but never before the contemporary era been leveraged is actinium HK2. HK2 is human kallikrein 2, which is very closely related to PSA, but is membrane bound in addition to being soluble, as unlike PSA, which is just soluble. And we are adaptively dosing this, so they get one single dose and then don't get redosed until they progress in order to avoid what otherwise would be emerging interstitial lung disease and also persistent thrombocytopenia. So I just wanted to have this slide here as an example of a new target, adaptive dosing, avoiding the dose-limiting toxicity of current small molecule-directed, PSMA-directed alpha therapy in one agent.
Yeah.
And Tanya has experience with this drug, as does Karen, and they have a maybe objective view of these data. So we'll let them speak to it.
No, I mean, the activity we've seen on trial, as those who can see the slide, is impressive. And I think the adaptive strategy is certainly what's moving us forward. Toxicity-wise, there was pneumonitis as an unexpected toxicity that seems to be getting sorted out with this adaptive dosing, but certainly something new relative to at least our experience with lutetium.
I've been a little surprised by the cytopenias, given that it's an alpha particle with a narrower range of energy deposition. But, I don't know if that just speaks to the population or if you have any thoughts about...
It's an antibody, so its clearance from blood is much slower than a small molecule. Now, that's a double-edged sword, so it does have a longer circulating half-life than a small molecule does. On the other hand, that may account for its really long duration of effect because the internalization and retention in the tumor is longer as well. So at least we hypothesize, which is why, like after one dose, you can see a treatment effect that's 6 months, 12 months, et cetera. So it speaks to what we started this morning out with in discussing the bispecific antibodies, is finding the right molecule that minimizes tox and maximizes treatment effect. And in radioligand therapy, a lot of that isn't just payload, but also the size of the targeting molecule. And this is a big targeting molecule. Yeah, go ahead.
I was going to say, sounds like a good example of sort of that this is just the beginning of the road, right? Sorting out target and molecule and sequential therapy, you know what I mean? This is the beginning of the story, not the end.
Right.
But the duration of responses is really impressive.
Yeah.
Yeah.
All right.
Because actinium is not just a single alpha, it's actually a decay cascade. Has there been biokinetics to look at the byproducts? Because if it's blood-bound longer, these secondary alphas and betas are in that chain and potentially are localizing elsewhere besides the tumor cells.
Great point, Gary.
Yeah. All right, this is the last slide, very simple slide. This is basically just to say this field is exploding, right? I mean, like I said, beginning of the story, I can't even count how many companies sort of involved. Find your favorite company in there. The field is sort of exploding, and I think we'll probably have... Tom's telling me to hurry up, boy. I mean, now I've seen everything. We're finishing, yes. I'd like to thank all the prostate cancer panel. Thanks for a great session.